Good evening, everyone. We welcome you on this occasion of International NASH Day on this INASL webinar. To set the ball rolling, I'll invite our current president, Dr. P.N. Rao, to say a few words. Dr. Rao, please.
Thank you very much, Dr. Kaushal. And so let me share some of my slides, about the International NASH Day. It's a very nascent, really. The International NASH Day is a very nascent one, just started in 2018. And the strategic importance of the NASH we all know, and then we all dedicate ourselves for all the international days, and then I find that is a very, very important step that has been taken by the world societies. And you can see here the importance of this, and 10th June is the day, and we do the International NASH Day. And you can see on the left-hand side, you've got a Global Liver Institute. It is an NGO, and it is this Global Liver Institute has taken the initiative of starting the International NASH Day. On the right-hand corner, you got the logo of the International NASH Day. And on the center, you got how to go about, and also the website where there is an extensive information is there, including the lean NASH. I was surprised to find that there is an information on the pediatric NASH, and also on the lean NASH. Also, there is some amount of information is there, and there is also a reference to some of the drugs which has been from our country. And the two panels which shows there are indeed 80 partners are there within a very short time, about 3 years. And the 26 countries have already participated. They have said yes to participate in International NASH Day. And you can find that, our INASL is also there. And this is held annually on the June 12th, since the June 10th, since 2018. And 2020, it has gathered, momentum. And we know that the strategic importance of the NASH and the two major liver scientific societies have already supported, that the ASLD and the ASL. On the left-hand panel, you will see all the international non-governmental organizations. The ones in the red are the INASL, that is our society, and the SASL, South Asian Association for the Study of Liver Disease, of which Dr. S.P. Singh, the president-elect of the INASL, and he is the president of in fact, he is the originator and also the president of this SASL. On the right-hand corner, you can see that, so many organizations and then foundations are there. In fact, this being an important activity, anyone can just join this and get them approved by this. And as you know, that one of the earliest biomarkers which we had is our own hand. And in this, we have got the non-invasive testing for NASH. Interestingly, NASH and fibrosis, we are all accustomed to hear about the fibrosis. And here we are going to hear about the NASH also, and chaired by Dr. Acharya and Abraham Koshi. And later we'll be having a very wonderful debate, which is chairpersons are Professor Rakesh Agarwal, and then who has been our immediate past president, and charismatic Professor Usha Datta from PGI Chandigarh, and two, and then energetic Professor Ajay Duseja and Abhijit Chaudhary, and then very oratory skills, from you can see from Abhijit Chaudhary's now about the two debate, and followed by the panel discussion by Professor S.P. Singh will be the moderator. And you can see Dr. Abha Nagral from Mumbai, Dr. Nitin Sharma from AAG, Dr. Raki Maliwal from ILBS, and Charles Pankaj from Kerala. And this is, let me now hand over the mic to the chairpersons, Professor Acharya and Professor Abraham Koshi. And thank you very much. I'll stop sharing the slides, please. Over.
Thank you, Dr. Rao. I'd like to introduce Dr. Stephen Harrison. He's the medical director of Pinnacle Research, Clinical Research, and president of Summit Clinical Research. He's a visiting professor at the University of Oxford and has over 200 publications in NASH, and his interest also includes hepatitis C. He will be talking to us now about non-invasive testing for NASH and fibrosis. I request Professor Harrison to please give us the talk.
Well, thank you very much for this wonderful opportunity to present to your group. It's certainly an honor to be here on International NASH Day. It's certainly come a long way. I remember starting International NASH Day back in 2018 and have enjoyed watching it grow. I think it is critical, it's vital to increase disease awareness. And that cannot happen without days such as this and patient advocacy groups like the Global Liver Institute. So thank you again for having me, and I look forward to today's events. And we'll start by giving a short lecture. Let me share my screen and pull up the presentation. Hold on just a second. Okay. Can you guys see the screen okay?
Yes, yes.
Excellent. Okay, well, again, thanks for the wonderful introduction. I reside in San Antonio, Texas, which I consider the epicenter of fatty liver for the United States. And so we have a great opportunity to research this disease. And my interest in this field goes back to the turn of the century back in 1999 to 2000, when I first began researching fatty liver. And as many of you know, way back then, there was very limited data we had relative to epidemiology, natural history, non-invasive testing, diagnosis, and certainly treatment. My interest lies in this entity, non-invasive testing for non-alcoholic fatty liver, as well as developing drugs to treat the disease. So today I get to speak to one of my favorite topics. These are my disclosures. I work with many biotech companies in the field in designing both non-invasive testing strategies as well as drug development. So many of you know these facts already, but NAFLD is an umbrella term, and it encompasses everything from isolated steatosis through ballooning inflammation onward to fibrosis, cirrhosis, and hepatocellular carcinoma. This disease is increasing in prevalence, and it's linked directly to the rising trends of diabetes and obesity. You see on the left a graph looking at what is anticipated to be the upward trend of diabetes in the United States between 2010 and 2050. And we're well on our way to accomplishing that, unfortunately. As far as obesity, we see very similar trends here around the world. I would assume it's probably the same in India as it is in other countries and continents. When we talk about fatty liver disease, it's important to understand that this is a continuum, and it's linked to lipotoxic fat. This lipotoxic fat, in a percentage of patients, approximately 25% of fatty liver patients, will lead to an inflammatory process that ultimately triggers the activation of stellate cells and the formation of collagen, which, if left unchecked, can lead to cirrhosis. There was a wonderful publication by Arun Sanyal a couple years back in 2018 that highlighted this growing prevalence of disease, highlighting that about 16.5 million cases in 2015 were projected to grow to 27 million cases by 2030. And maybe more importantly, some of the data that was modeled is important to share with you today. So from that paper, it is projected that by 2030, we'll have a 168% increase in decompensating liver disease, as well as liver-related death, and 137% increase in hepatocellular carcinoma linked to fatty liver disease. To that point, I want to highlight two publications on data that we generated at Brooke Army Medical Center in San Antonio, Texas. The first slide, the first bar graphs on the left, was a study that we published in Gastro in 2011, collecting data on 328 patients prospectively from 2007 to 2010. And we determined the prevalence of NASH by liver biopsy to be 12.2% in this population of middle-aged Americans determined to be around 55 years of age. Importantly, when we look at fibrosis stage 2 to 4, 2.7% of the population were identified as having that degree of fibrosis. Let's fast forward approximately 8 years to the next study. Same population of patients. We doubled the number of people included to 664. Again, prospectively defined by liver biopsy. The prevalence of NASH was 14%. Again, middle-aged population around 56 years of age. But more importantly, just as the prevalence of NASH remained relatively consistent, if not increasing a little bit over this 8-year period of time, what we noticed is the significant increase in advanced fibrosis from 2.7 to 5.9%. And I think this parallels the modeling that Arun Sanyal and his group published on the projection of what's happening with NASH and, more importantly, advanced NASH between 2015 and 2030. And this suggests that prospectively obtained data confirms what was originally published in a modeling format. So let me shift gears and talk about non-invasive tests. And I think these can be evaluated for 3 different contexts of use, and we'll discuss all 3. Diagnosis of NASH and fibrosis, this so-called at-risk NASH population, and then measurement of a therapeutic response. As we begin to get therapies that are moving the needle in fatty liver, we need to be able to non-invasively assess their efficacy. And finally, long-term patient outcome data. For the purposes of this talk, I've not included everything because I wanted to leave time for other discussions, but I'm giving just a highlight of what is coming. So it's important that the proper use of non-invasive tests are brought to bear. And this is done by including demographic information, imaging studies, as well as serum-based lab tests. We can put them in a funnel and we can enrich for NASH with F2 to 3 fibrosis. And this is work originally put together by Naga Chalasani at Indiana University. So let's break these tests into serologic tests, where we have simple scores that are readily available in clinical practice and even have online calculators that could be used to derive the score, to proprietary predictive scores such as liver-fast, NIS4, and ELF. And then finally, imaging studies, mainly focused around elastography with FibroScan, ARFI, shear wave elastography, and the newer modality, VeloCure, made by Sonic Insight, which is an S-wave modality. Let's first start with a very simple liver chemistry test, AST. Here is some data that I published back in 2008 in Gut, in a large population of fatty liver patients that I obtained while doing my fellowship at St. Louis University under the tutelage of Elizabeth Brunt and Brent Neuschwander-Tetry. Here we look at over 800 patients that were evaluated histopathologically in a cross-sectional retrospective manner. And we focus on AST and AST-ALT ratio. And as you go from left to right, fatty liver alone to NASH with stage 0, 1 to 2, and finally stage 3 to 4 disease, you see a rise in AST, as well as concomitant increase in the AST-ALT ratio. Very simply speaking, you can use AST and AST-ALT ratio to predict the probability of advanced disease. In fact, the AST-ALT ratio carries an odds ratio of 9 for predicting advanced liver disease. Moving into some of the scores that are very simply obtained through an online calculator, it's interesting that both of the NAFLD fibrosis score and the FIB4 include AST in their paradigm. On the left, we see the NAFLD fibrosis score, and we see a low cutoff and a high cutoff that correlate with negative and positive predictive values. On the right, we see a similar paradigm for FIB4 with a low and a high cutoff. Now, these low cutoffs are very good at excluding patients with F3 to F4 disease. The high cutoff is very good for predicting the probability of F3-4 disease. The problem is that there's a wide indeterminate range for both of these tests that are approximately 30% or so, depending on which study you look at. So as we look at this very simply, if you have low probability of F3-4, it doesn't mean you don't have NASH with F2 disease. It just means you don't have F3 or F4 disease. And so you could argue if you don't have F3 and F4 and you're constrained in your healthcare delivery system, that primary care management with lifestyle modification would be important in this population. Alternatively, if you were predicted to have a high probability of F3-4, then specialty referral for further workup and even potential consideration for clinical trials would be important. Alternatively, if you're in the middle group, that indeterminate group, we suggest a second non-invasive test, and I'll speak to that momentarily. Now, moving on to some of the proprietary tests, here's one you may not know much about. It's called Liver Fast, and it is a collection of 10 different biomarkers that you see highlighted on the left. It gives you a readout that you see on the right, this color-coded fibrosis activity and steatosis score using the SAF system designed by Pierre Bedoza. And you see the analytes that are included on the left for each of those variables. An illustration on the right shows that for F3, 0.63 would predict the probability of F3. And with a score of 0.4, this would be minimal activity, and with a score of 0.61, moderate steatosis. It's also important to note that this scoring system was derived using a neural network approach and a machine learning approach, not just a binary variable such as FIB4 or NAFLD fibrosis score, BARD score. In other words, it wasn't just when we look at BMI, for instance, it wasn't just BMI greater than 30, yes or no, which is basically the way the other scoring systems that we use routinely have done. This is more of a continuous variable. And by doing so, the hope is that we're increasing the precision and the accuracy of this test by using these continuous variables in a neural network approach using artificial intelligence. So there's more to come here. We need to generate more data, but it's exciting to see that we're moving forward in that regard. Now, what about NIS4? Well, NIS4 is another proprietary serum-based test that includes the microRNA, alpha-2 macroglobulin, and YKL-40, as well as hemoglobin A1C. And this data was generated predominantly off the phase 2B elafibranor trial by GenFit. We published this data in Lancet GastroHep back in 2020. And you see, again, a low cutoff and a high cutoff with an indeterminate range that's in line with what we see for FIB4 and NAFLD fibrosis score. And this is designed specifically to identify patients with NASH with a NAFLD activity score of 4 or more with F2 or greater fibrosis. So slightly different than the NAFLD fibrosis in FIB4 and Liver Fast, which were used to identify all comers with NASH that had some degree of fibrosis. However, this particular score is designed to fit the inclusion criteria for FDA approvable studies. Well, what about ELF? Well, we know this is a blood-based test that's linked to fibrosis and matrix turnover of collagen. Within this test, you see 3 distinct analytes: hyaluronic acid, P3NP, in TEMP1. And I highlight this one paper published in Journal of Hepatology in 2020. This was a meta-analysis of 11 studies. The ELF test had a sensitivity of greater than 90% for excluding fibrosis at a threshold of 7.7 to achieve a specificity of 90% for advanced and significant fibrosis. Thresholds of 10.8 and 9.86 were required. Now, this test is about to go live, at least in the US, as a serum-based test commercially available. Shifting gears to image-based modalities for estimating liver stiffness, we see 4 of them listed here: transient elastography, shear wave elastography, MR elastography, and S-wave elastography. Now, you may know about the first 3. Let me tell you a little bit about S-wave. It measures volumetric elastography and attenuation. 5 to 10 image volumes are required. There's a large region of interest that allows large measurements of volume. It's point of care. It can be done at the bedside and takes approximately 10 minutes. When we compare each of these 4 modalities, we see the excitation source listed here, the volume of measurement, the depth of measurement, the imaging type, and accessibility. When we look at transient elastography and S-wave elastography, we see these are both able to be done in clinic, and they both use ultrasound, although with transient elastography, it's one-dimensional, and with S-wave, it's 3-dimensional. In addition, the depth of measurement is different. 3.5 to 7 centimeters for transient elastography and up to 15 centimeters for S-wave elastography. First, let's mention FibroScan. So this gives you 2 variables, a CAP score, which quantifies the degree of liver fat, and liver stiffness, which correlates with fibrosis. This is an example of the propagation map seen, and we see here that the measurement is from 25 millimeters to 65 millimeters. Now, one of the complications with this is that if you have significant subcutaneous adipose tissue, as highlighted in pink, that often that can interfere with the read because it can be deeper than 25 millimeters. And when that occurs, it can give a false elevation to the CAP and even the KPA. So it's important to look and see the depth of subcutaneous adipose tissue when doing this scan. This is a representative report illustrating a CAP score of 179 on the left and a KPA of 3.5 on the right. This would be a completely normal scan. I would love to tell you that it's mine. However, I'm not sure whose this is, but it highlights what normal looks like. It also highlights the importance of ensuring an adequate exam. You want to make sure the IQR median is less than 30 and that you have at least 60% valid measurements. Here on the right, you see 10 out of 10 or 100% of the measurements were valid. And that's an important variable to remember. You need at least 60% success rate for an adequate exam. Now, what is the right cutoffs? And I illustrate a nice study here published in the Blue Journal in 2018, looking at the balanced priority for predicting fibrosis of any stage versus none. And it turns out it's around an 8.6 kPa. Now, what about CAP? Well, to predict fatty liver, the ranges are all over the map. In Asia, the values tend to be less than they are in the US. Vincent Wong has published that around 240 to 250 predicts fatty liver in his population. In the United States, it's more around a value of 280. Now, it's important to also know that when you use FibroScan, both the KPA and the CAP lack sufficient positive predictive value to be used alone to predict NASH and fibrosis. I assure you, you will often overcall disease if you use this study alone. Here's an example. So again, FibroScan is most reliable in ruling out advanced hepatic fibrosis. In fact, fibrosis is unlikely with a value less than 6 kPa. However, when we begin to increase FibroScan values, I begin to worry when the value crosses 8.5. At that point, I tell my patients that they're at risk for having some degree of fibrosis. It's important to note that overestimation of fibrosis can occur in cases of inflammation, such as acute hepatitis, cholestasis, liver congestion, obesity, as noted by the increased subcutaneous fat level I've already highlighted, and if mast lesions are present. I can reassure you that values greater than 20 do correlate well with portal pressure. However, values less than 20 and greater than 8.6 do not necessarily relate to a specific fibrosis stage. Just want to highlight a couple points here with Velacure. This is the S wave. That there's a deeper depth of penetration with the S wave versus transient elastography. That's illustrated here. It's 15 centimeters versus about 7 for FibroScan. And this allows for a broader evaluation of liver tissue. Now, when we look at this from a region of interest perspective, that's highlighted by the cutout square. And we see that you're looking at about 100 centimeter cube being evaluated compared to about 3 centimeter cube for transient elastography. Now, when we look at the small amount of data that's been generated to date, this is published as an abstract from the liver meeting in 2020, the double ASLD liver meeting, in 31 patients with NASH and hepatitis C that achieved a sustained virologic response, as well as healthy volunteers who underwent this S-wave elastography versus MR elastography. And you see a very nice correlation. Now, while this is early days, it gives me excitement to say if we have a point of care test that we could use in clinic that correlates with MR elastography, that would be a very nice thing to have. So let's talk about MR elastography. It's not readily available on every street corner, but in a lot of centers now throughout the world, particularly in academic centers, it is available. At least the 2D MR elastography is. And here we see data from Rohit Lumba's group highlighting the AUROC for the diagnosis of advanced fibrosis is very good. In fact, it's the best we have relative to any other study. In this particular study for stage 3, we're looking at values of around 3.6 kPa or higher. Many studies have been done comparing FibroScan to MR elastography, and here's a head-to-head prospective comparison in 104 patients. And you see that at the low stage of disease and the high stage of disease, a nice separation between MRE and transient elastography. Unfortunately, similar to FibroScan when I mentioned it earlier, it's not that great at distinguishing stage 2 from stage 3 disease. And we still have work to do there when looking at MRE or transient elastography as a single test. So this gets me to sequential testing. And this is an important paradigm, I believe, that many of us advocate now. First, we do the initial non-invasive test. And we see that we can get a certain percentage of people where we rule out disease and a certain percent where we rule in disease, but a wider indeterminate range. If we apply a second non-invasive test, we shrink the indeterminate range. So the sequential use of NITs maintain the sensitivity and specificity while enabling the classification of a larger proportion of patients. So what are some of these tests? This was a study as part of the Litmus Consortium where I chair the work package 5 on imaging. We recently published this data in Gut. Now, this is a combination evaluation of FIB4 with FibroScan, looking at an individual patient data meta-analysis from 37 primary studies with over 5,700 patients. An algorithm combining FIB4 and liver stiffness measurements sequentially with upper cutoffs to rule in and positively diagnose disease were obtained. I highlight those for cirrhosis. Here you see a FIB4 greater than 3.48 and a liver stiffness measurement greater than 20 or 98% increased specificity when you increase the FIB4 value to greater than 4.6 and the liver stiffness measurement to greater than 28. I encourage you to review this paper, and you can see where the different cutoffs come together based on the specificity that you would like to have in your clinical practice. There's also a combination of FibroScan with AST. We published this data last year in Lancet Gastro as well. Again, you see two different cutoffs, a rule out zone and a rule in zone. And this is, again, a test that you can do readily in your clinic if you have access to a FibroScan. There's a FibroScan app. It's called My FibroScan. It looks very similar to this. You just impute the CAP score, the KPA score, and the AST in the center column here. And on the right-hand column, it gives you a readout. And that readout correlates to the probability of having NASH with F2 or greater fibrosis. Now, more recently, actually very recently, Arun Sanyal published his data from the UCSD NAFLD cohort, where he combined MR elastography with Fib4 and showed that when the value was greater than 3.3 for MRE, as well as greater than 1.6 for Fib4, the positive predictive value was 97.1 for predicting F2 or greater disease. This was subsequently validated in a Japanese cohort of over 200 patients, confirming the high positive predictive value. So in summary, we can link together a risk stratification algorithm for NASH fibrosis, starting with very simple biomarkers. And if they're low risk, then you just continually monitor the patient with lifestyle modification recommendations. If they're high risk, look for additional features of cirrhosis and then manage them appropriately. If, on the other hand, they're in the indeterminate range, perform one of the imaging studies I've already highlighted. If those are consistent with features of cirrhosis, manage them accordingly. If not, consider a liver biopsy. Finally, or secondly, moving on to therapeutic efficacy. There are non-invasive tests to predict response to treatment. The FDA gives us two endpoints for phase 3 clinical trials that are both based on histology. One is NASH resolution without worsening of fibrosis. The other is fibrosis improvement without worsening of NASH, or a more stringent endpoint, both of these criteria. Now, I very simply put this all on one graph. To date, I think this summarizes where we are very nicely. We can use MRI-PDFF. 30% relative reduction has been associated with improvement in the NAS score as well as NASH resolution. We can use ALT, greater than 17 unit per liter reduction predicts histologic response. And we can use some of the imaging variables listed on the right, MRE, CT1, or liver stiffness measurement. I caution you that these values I have listed are very early and need to be proven in subsequent prospective trials, but you can see various cutoffs that have been linked, at least in some cohort data, to improvement in histopathology. So how do we pull this together? This is a futuristic look at this by a good friend of mine, Naeem Al-Khoury, as well as Mazen Nareedin at Cedars in LA. If we start in the upper left, primary care providers will refer high-risk patients to specialists based on simple non-invasive tests. We'll then do advanced non-invasive testing, and once we have FDA-approved therapy, we can treat those patients. We can do follow-up non-invasive testing strategies, and if they've had a response, we can continue treatment. If they've had no response, maybe we switch therapy or we add therapy. What we still don't know is the ideal duration to assess response or futility, or the ideal cutoffs to predict response in the long term. And finally, long-term patient outcomes. This is exciting. We can now use serum-based tests and imaging tests to predict outcomes. I highlight ELF here, a serum-based test from data generated from the simtuzumab trial published in Hepatology in 2019. You see that ELF can predict the progression from F3 to F4 at a value of greater than 9.76. It can also predict a liver-related event in patients with F4 disease, and that's also important to highlight. Now, more recently, we looked at the data on ELF from the Stellar 3 and Stellar 4 trials. These were two negative studies with selonsertib, unfortunately. However, the non-invasive testing data that were generated has been very helpful. And what we see is that ELF scores of less than 9.8 actually give us a good chance of finding improvement in fibrosis without worsening of NASH. In other words, if you enroll a population of patients in a treatment trial and your ELF scores are less than 9.8, those are the people that had the greatest probability of improving fibrosis. Alternatively, when the ELF score was greater than 11.3, that predicted the probability that patients would progress in their liver disease, supporting the previous data I showed you from the simtuzumab data. About MRE. Well, this is data published from Alina Allen's group at the Mayo Clinic, and I find it incredibly helpful. For each 1 kPa increase in liver stiffness, patients are 3 times more likely to develop cirrhosis in the future. In addition, for each 1 kPa increase in liver stiffness, subjects with NASH cirrhosis are 32% more likely to develop decompensation. This is illustrated in this figure. Take, for example, a patient who has an MR elastography of 5 kPa. At 3 years from the first MRI, they have a 20% risk of decompensating or dying. I used this just yesterday in my clinical practice, where I had a patient who had an MRE of 7.7. I showed him this graph and I illustrated that his 3-year probability of decompensating or dying is somewhere between 30 and 40%. So what about multiparametric MRI? Well, this is a measurement that looks at a corrected T1 score, and we can use that to predict outcomes. We can also use it to predict NASH, and that's illustrated here. Liver multiscan has an AUC of about 0.84 when combined with liver fat. But I highlight this paper published in Liver International last year, looking at Kaplan-Meier curves. And I want to just highlight 2 of these. One is panel A, all-cause mortality survival stratified by CT1 greater than 825 milliseconds. You see that at approximately 3 years, the curves begin to separate, and it's significant at a value greater than 825 milliseconds. When we look at panel D, event-free survival stratified by CT1, we see 3 different colors, red, green, and blue. These correspond to 3 different values of CT1. At values of 840 to 990 milliseconds, that's illustrated in green, we see a separation in event-free survival. When values were greater than 990, the percent remaining event-free dropped significantly with a p-value that was less than 0.01. So I would like to conclude my presentation today. I thank you for your attention. The field is rapidly moving forward. I think if I present this again in 6 months, it would be even more detailed and more helpful, but I think we've come a long way in a relatively short period of time, and I hope you find today's data presented helpful in your clinical practice. Thank you.
Thank you, Dr. Harrison, for a brilliant talk and talking to us not only about various blood-based tests, imaging tests, sequential tests, their diagnostic values, and also the test necessary to assess their progression as well as regression, as well as monitoring, and the role of these values in treatment monitoring and predicting future complications. And that is a holistic approach, a holistic view you gave brilliantly within a short period of time. And because we have subsequent program, I don't think you will mind to answer certain questions which are in the chat box. And I can ask, the one question is, what is the reason of increasing AST-ALT ratio in patients as the fibrosis progresses? This question is why AST goes up as fibrosis progresses, where ALT doesn't proportionately go up. As a result of this ratio gets altered over a period of time.
That's a great question. There's been a lot of work done in that regard, and unfortunately, it's the understanding of why AST goes up and ALT goes down remains a mystery. What we do know is that ALT tends to peak at F3 disease, whereas AST continues to rise concurrently as you go from F1 to F2 to F3 to F4. And I think we often look at ALT in clinical practice. We use ALT to enrich patients for NASH clinical trials. But in the past 3 to 4 years, we've shifted gears a bit and have begun to look at AST as a predictor. And it turns out that it's actually better than ALT at predicting the degree of fibrosis. Now, just as important as I mentioned, ALT reduction of 17 units per liter corresponding to improvement in histopathology. And in the clinical trials I've done, and I've been a part of almost all of them, we've never seen NASH resolve and ALT not improve. But when we focus on the fibrosis component, I would encourage you to look at the AST reduction, because that is an important fibrosis biomarker, just like ELF is or PRO-C3 is, at predicting what's likely to happen to your patient. So again, that works as long as they're not cirrhotic. In a cirrhotic cohort, at least in my US population, very often, in fact, more often than not, ALT and AST are normal. They're less than 30. And in that situation, you can't really use those markers to predict response. But I do believe we're moving quickly into an era where we can begin to show regression of cirrhosis, even in the setting of NASH clinical trials. And maybe we'll talk about that in the panel discussion, but we have early provocative data from Akero and efruxifermin, an FGF21 analog, that cirrhosis can actually be improved in a relatively short period of time. That's hotly debated, but the data is out there and at least worthy of a discussion.
Thank you. Dr. Harrison, is that not true for most of the patients with fibrotic liver disease, like alcoholic fibrosis or hepatitis B virus or hepatitis C, where AST actually goes up disproportionately more than ALT, and both of them reverses when fibrosis reverses? That is true also in hepatitis C as well as alcoholics. That at least that.
Yeah, that's correct.
And I have another question. What is the maximum permissible IQR range for valid FibroScan report?
Okay, so let me break that into two parts. So for the KPA, you want to keep the IQR median less than 30 to maintain validity of the exam. For CAP, it's not as well validated, but ideally less than 40. So for CAP, IQR less than 40. For KPA, IQR less than 30. The other variable I mentioned that people tend to forget about is the success rate of the scan needs to be more than 60%. And let me give you an illustration. I'll have my technicians scan a patient 100 times trying to get 10 valid assessments. Well, 10 valid assessments out of 100 is a success rate of 10%. And I have to remind them that even though they gave me 10 valid assessments, the probability that that scan is inaccurate is very, very high because the success rate is way less than 60%. So just keep that in mind as well.
And there is another question from Dr. Jayanti. She told, why can't we clusters of component of metabolic syndrome predict NASH progression or cirrhosis? Instead of so many tests, right? And using them sequentially, and also for which you may need sophisticated labs, for example, ELS, or for example, how you want to say other serum-based test, right? So you need a lab which may not be available. Whereas fatty liver disease is prevalent globally and all over the world. So she is asking, can you give simplified clinical metabolic, right?
Yeah,
syndrome support to predict NASH or cirrhosis?
So when we look at the data that we generated prospectively on the prevalence of NASH. Again, that paper is recently out in Journal of Hepatology. What we found is when we looked at additive components of metabolic syndrome, diabetes, obesity, hyperlipidemia, hypertension, that we didn't increase the probability of diagnosing NASH significantly. And I'll take diabetes as an example. So fatty liver was found in about 70% of our diabetic patients using MRI proton density fat fraction. When we prospectively biopsied those patients, the prevalence of NASH was found to be 35%. When we looked at an obese diabetic population with either hyperlipidemia or hypertension and the genetic ethnic group highly enriched for NASH, the Hispanics, we were only able to get our NASH diagnosis up to 46%. So in what I would consider my highest risk patient population in San Antonio, a postmenopausal Hispanic female with obesity, diabetes, hyperlipidemia, and hypertension, we found the prevalence of fatty liver to be 90%, but the prevalence of NASH to be 46%. So you can use demographics, you can use risk factors clinically to enrich your population, but it's not enough to do that alone. Okay, so the next simple thing to do is look at the AST to ALT ratio. When that ratio is around 1, I mentioned very early in my talk, the odds ratio for NASH with fibrosis is around 9. So you can look at the ratio, but the ratio needs to be abnormal, meaning the ALT and AST need to be higher than, say, 40. So what's the data with just looking at an AST above 40? Well, it's actually pretty good. In fact, that's how we designed, the reason we designed the FAST score was combining FibroScan plus AST, because AST is actually relatively predictive on its own. So in summary, I would say the more demographic risk factors you have, combined with either an AST above 40 or an AST-ALT ratio of around 1, you put those two together, that's highly predictive of a patient having NASH with some degree of fibrosis. It's just not going to be as clean as if you combine some of these imaging modalities like a FibroScan or an MRE or some of the other techniques I mentioned. There we're more likely to be able to tell you a specific stage of fibrosis rather than just saying, hey, you have NASH with some degree of fibrosis. The only caveat to that, I would say, is cirrhosis is relatively easy to pick up if your clinical data suggest a platelet count less than 150, an AST-ALT ratio of greater than 1. So clinically, when we separate alcoholic liver disease from non-alcoholic liver disease, AST is never higher than ALT in NASH unless you have cirrhosis. Now, in cirrhosis, the AST will often be higher by a little bit, not a 2-to-1 ratio like alcohol, but maybe a 1 to 1.5 ratio over ALT. And then we published this a long time ago, but particularly in postmenopausal women, you'll see a slight bump in the alkaline phosphatase. So if you have an example would be a 60-year-old female that comes to your clinic with obesity and diabetes, and you do a lab test on her and you find her AST is, say, 65 and her ALT is 50, and the alkaline phosphatase is 130. Look at the platelet count. If that's anywhere near 150, that patient has cirrhosis. So that's about as basic as we can get it without bringing to bear some of these proprietary blood-based tests or even imaging-based tests that you may or may not have access to.
Thank you, Dr. Harrison. I think it's the time, and I have been asked by the organizer to close the session so that we can move on to the next session. We have a further session on this NASH day, and Indian National Association Study of Liver is grateful for this elegant talk to us and discussing in such an elegant manner and probably answering most of the questions that people raised. And I hope you will be again joining us in future, elucidating your further work and the progress on this problematic disease, which is so prevalent. Thank you, Dr. Harrison, so much.
Thank you very much.
Thank you.
Thank you.
Excellent.
And I will hand over the session to the Dr. Rao and Dr. Kausal Madan to progress further in the evening.
Right. Thank you, Dr. Acharya, Dr. Koshi, and Dr. Stephen Harrison for a wonderful talk and discussion. So let's move on. I'll hand over the mic to Dr. Rakesh Agarwal to take the session further.
Thank you, Dr. Kaushal. Good evening, everyone. Or if you are at another time zone, then appropriately, good morning, good afternoon. Today, we are going to, in the next session, have a debate, and this relates to treatment of NASH. First, we will have Dr. Ajay Duseja, and he will be talking about indicating that lifestyle modifications are adequate for the treatment of NASH. Followed by that, there will be a lecture by Dr. Abhijit Chaudhary from Kolkata, who's going to argue that we need pharmacological therapy. So, Ajay, I know you were asked to take 15 minutes, but if you could take 2 or 3 minutes fewer, that will be great because we are running late. Thank you.
Thank you, sir. Let me first share my slides. So can you see
we can see this. Thank you.
Okay. So at the very outset, again, I think I'd like to start by thanking Professor Stephen Harrison for his wonderful talk and agreeing to be part of this webinar. I know he has a lot of other commitments today, and he has a meeting immediately after this, and I would like to thank him for staying even for the panel discussion. Secondly, I would like to thank Dr. Kaushal Madan, Dr. P.N. Rao, and Dr. S.P. Singh from NASL for giving me this opportunity to be debating on this topic. I'm very happy to do that. The only thing I'm not happy about is that I have to debate it with one of my dear friends, Dr. Abhijit. But I'm pretty sure the kind of data we have, I'm going to convince him and everyone that lifestyle interventions alone are sufficient for treatment of NASH. So let's start. I think I don't think I need to tell this audience about the distinction between the NAFL and NASH. We can have, NASH can be again fibrotic NASH, which is with fibrosis or without fibrosis, but it has to have, inflammation, which is picked up, on histology by ballooning and by the lobular inflammation. And obviously it has the propensity to progress on to cirrhosis and its complications. So what we're talking today is the treatment of only NASH with or without fibrosis. We are not talking about NAFL, and we are not talking about cirrhosis or, the advanced form. So we are talking only about NASH, which can be, with or without fibrosis, as I said. So let me start with very basic, pathogenesis of NASH. We know there are genetic and the environmental factors which are involved in the pathogenesis of NAFLD in general and NASH in particular. But in the environmental factors, I think if you look at this, I think it is nothing but it's our lifestyle, and it's predominantly, the sedentary lifestyle and the high calorie rich food, which leads to, diet-induced obesity or adiposity, leading on to, peripheral insulin resistance with inflow of free fatty acids from the adipose tissue into the liver, also leading on to de novo lipogenesis, and diet also adding on to the free fatty acids. So I think we understand that the lifestyle predominantly, the sedentary lifestyle and the diet plays a major role, which can even affect, our gut microbiota in, in the pathogenesis of NAFLD and NASH. Having said that, I think let me also show you some Indian data that how common are these, the adiposity, which I said, or the obesity, which is linked so commonly to NAFLD. I mean, people keep talking about lean NAFLD and all. So this is our recent Indian data interim analysis of our Indian Consortium on Non-Alcoholic Fatty Liver Disease, which we presented in the recent APASL meeting of more than 4,000 patients. And we had the data on metabolic risk factors in close to 3,500 of these patients. And look at this, but for around 10-11%, rest 90% of all our patients were either overweight or obese. So 73% obese and 16% overweight. And if you look at that, I think the central obesity was seen in around 83%. I mean, I'm just trying to emphasize that the kind of patients we see in our country are predominantly overweight and obese, and which is the determinant of, you know, the fatty liver and the NASH. So I think I'll stop this here and just emphasize on the role of, you know, lifestyle in the pathogenesis by putting this, you know, recommendation and the evidence by the EASL, which says that there's a very high quality evidence and a very strong recommendation for the unhealthy lifestyle, which plays a role in the development and in the progression of, you know, NAFLD. And when we say lifestyle, it is nothing but it is basically your food, high calorie intake, in general, fat, fructose, and your sedentary behavior leading on to obesity and NAFLD. So having said that, it means that I think if the lifestyle is so closely involved in the pathogenesis of NASH, obviously this would be very important in the treatment of NASH. So when we talk about lifestyle interventions in NASH, I think we can divide them into, you know, different areas. One could be, you know, even the control of lifestyle interventions to control risk factors like diabetes, hypertension, dyslipidemia would also be a lifestyle intervention. Then also somebody who's say normal weight, so-called lean NAFLD, only physical activity would also be, you know, lifestyle intervention. And we know that physical activity per se, even without weight loss, can lead on to reduction in the liver fat. There are other lifestyle interventions which are beyond diet and exercise, like, you know, the role of coffee, role of circadian rhythm, sleep, your shift work, social jet lag, alcohol. So I think the time doesn't permit me to, you know, get into all those lifestyle interventions. So for the sake of this debate, what I'll be focusing on is the lifestyle interventions which lead on to weight reduction in overweight and obese people with NASH. And these lifestyle interventions could be diet, exercise or physical activity, and the best we know is the combination. So I'll be now showing you some data that this, especially the combination of diet and exercise as lifestyle intervention in obese and overweight patients with NASH are sufficient enough to treat these patients and at least show the histological response. Again, I think let me start with showing you the treatment recommendations by two important societies, the EASL and ASLD, and look at this again. The EASL says with a moderate quality, you know, evidence and again, very strong recommendation that in overweight and obese NAFLD, 7 to 10% weight loss should be the target by lifestyle intervention. And that results in not only improvement in liver enzymes, but also in liver histology. So which means improvement in NASH. Also, the ASLD says that a combination of the, you know, reduction in your calories by maybe 500 to 1000 every day with moderate intensity exercise is very good for, you know, weight loss. And if you're looking for only, you know, improvement in hepatic steatosis, 3 to 5% weight reduction is, you know, good enough. But then if you're looking for the improvement in NASH and fibrosis, which is the topic today, 7 to 10% weight reduction would be, you know, good enough by lifestyle intervention. So I think, you know, these treatment recommendations obviously have come from lots of studies, and I'll now be showing you some data to support these recommendations both by EASL and ASLD. So as I said, there are many studies, I think, which people have done on the lifestyle interventions, especially on the combination of, you know, diet and exercise for both NASH resolution and fibrosis improvement, which are, you know, we just heard Professor Stephen saying that these are the endpoints for treatment, even with pharmacotherapy or for any kind of, you know, treatment. So there are a large number of studies. Some of them are, you know, single arm, some of them are randomized trials, and majority I have picked up only those studies which have actually histological endpoint showing you the improvement in NASH and maybe showing you the improvement in fibrosis also. Again, for the sake of time, I'll elaborate on only 2-3 studies, which are very, very important, you know, which gives us the message that yes, lifestyle interventions with weight loss of around 7 to 10% is good enough in improving the histology in patients with NASH. So this is one study around 10 years back from US, Small number, 31 patients with overweight and obese biopsy-proven NASH, and they were randomized to, two groups. One was the intensive kind of lifestyle interventions, which was with diet, exercise, and also behavior therapy. And the nutritionists and the educators were kind of, guiding them almost every week kind of thing. So it was quite an intensive kind of lifestyle intervention. And they were given the targets of, weight loss. And the other was just an education, structural education program where they were just told the importance of, again, lifestyle interventions. So both were lifestyle interventions. One was, with the behavior therapy, with the intensive kind of, lifestyle intervention. So when you look at the results at 48 weeks, which is close to 1 year, I think there was a higher weight reduction in the group which was given the intensive lifestyle interventions, 9.3% versus 0.2%. Look at the reduction in NAFLD activity score, 72% versus 30%, and change in the NAFLD activity score again was higher in the intensive group. And this percent weight reduction correlated significantly with the improvement in the NAFLD activity score. And finally, when they divided their patients into less than 7% weight loss versus more than 7% weight loss, I think the things were very, very clear that there was a significant improvement in steatosis, lobular inflammation, ballooning, which are all we know are the components of NAFLD activity score, much more in the, the intensive lifestyle intervention group in comparison to the structure. They could not, demonstrate the efficacy as far as the hepatic fibrosis was concerned. Then there was another study again from US, again a small number, 45 patients with NASH. Again, the biopsies were done at an interval, maybe around 4 years and 4.5 years. And around 12 of these patients also had undergone bariatric surgery in this study. Others were lifestyle interventions, but the message is that when they looked at the fibrosis regression in these patients, they came out with a figure that those who had, 10% or more weight reduction by lifestyle intervention or by bariatric surgery, I think they showed significantly regression in their hepatic fibrosis, which is seen in this, diagram very, very clearly. And on multivariate also, 10% or more weight reduction was associated with around 8 times, chances of, reduction in hepatic fibrosis. And finally came this very large study from the Spanish study, which had around 293 patients, and 261 of these actually had paired biopsies at a gap of, 52 weeks. But I think the importance of this study is this was a single arm study, non-interventional, and this was done in a clinical practice, but not the kind of, intensive lifestyle interventions, which I said in the first POMRAD study. These were the usual kind of lifestyle interventions which were given to these patients. And please remember these figures, because when we come to the pharmacotherapy, we will have to compare this. 25% resolution of NASH, 47 or 50% reduction in NAFLD activity score, and 20% regression of fibrosis. So I think these figures are very, very important. And but overall, yes, we will discuss that only 30% of the patients could lose 5% or more weight, and 10% could lose, 10% or more weight. But then the degree of weight loss was independently associated with improvement with all histological parameters of NASH. And let me show you a bit more detail here. Look at this weight loss and the histological response relationship. If you have 10% or more weight loss, your chances of, improvement in steatohepatitis and NAS improvement is close to 100%. 7 to 10%, again, 88%, 64%. 5 to 7% is 26%, 62%. So as the weight loss goes up, your histological improvement, increases. And same is true for your fibrosis regression. Again, look at here. If you have 10% or more weight reduction, 45% of patients had regression in fibrosis, and 55%, has stabilized, kind of fibrosis. But then if your weight loss was, less than 5%, then obviously the figures were less. So which means that you need more weight, reduction, maybe 7 to 10% or 10% or more to actually get the successful resolution of NASH and the regression of fibrosis. They also came up with, certain predictors of response, and they said that if you have a female patient, and if you have diabetes at baseline, and if you have a BMI which is more than 35, many balloon cells, I think then probably your chances of responding to lifestyle may be lesser than those who don't have these risk factors. But even in these patients with poor predictors, if you are able to lose weight of 10% or more, I think your histological improvement is close to 100%. Whether you're looking at the NAS improvement or whether you're looking at the NASH resolution, I think it's close to 100%. So the key is the amount of weight loss, which I said is 7 to 10% or 10% or more. Thereafter, I think there have been many meta-analyses which have, compiled these studies, but ultimately the answer is that combination of interventions is most effective, and it is the 5 to 10% weight reduction depending upon the kind of improvement you're looking after, whether you're looking only for the inflammation or you're looking at the improvement in fibrosis. And this has to be by reduction in your calories by maybe 500 to maybe 1000 kilocalories a day, and maybe around 150 to 200 minutes of exercise at least 5 days a week. So now this is what the lifestyle interventions data says. Now, does the question which is being debated is, does the addition of pharmacotherapy or drugs, increase these figures of NASH resolution and fibrosis regression? I think this is what we have, and we know that I think that none of the drugs have been approved by the FDA or EMA for the treatment of NASH. That is the first thing. Societies, the ASLD, EASL, and INASL, we do suggest some of the drugs, for the treatment of NASH. But look at the data. This is the, the landmark Prevalence trial, and the primary endpoint of Prevalence was the reduction in NAS score of 2 or more points. And look at this. It's 43% with vitamin E and 34% with pioglitazone. So what the figures I showed you for NAS with the lifestyle intervention was 50% NAS improvement, right? And there was no fibrosis improvement. And the figures I showed you for fibrosis improvement with the lifestyle interventions in the last study was 20%. Let's go to the other molecule which is available only in India. And this is the study which was presented in a parcel, still is under publication with saroglitazar, 102 patients. Again, the primary endpoint was 2 or more point reduction in NAS, which was seen in 52% in the sero group versus 23% in the placebo, which is close to the lifestyle intervention which I said. But where is the improvement in fibrosis? That data is not available, and probably this drug may not be able to improve the fibrosis. Finally, the drug which is the talk of the town, which is obeticholic acid, not approved by any society, not approved by any regulatory agency, but look at the the intentions to treat
Dr. Seja, you need to stop somewhere. So
okay, sir. Okay, right. I'll just take maybe 2 minutes.
Yeah.
So this is the the improvement in fibrosis and the resolution. The fibrosis improvement is only 23%, even with obeticholic acid, and there was no difference in the NASH resolution. So the question is, why are we then debating? If the drugs are really not helping, why are debating? The problem is that, many patients are not able to do the lifestyle interventions. They're not able to do the exercise because of the cardiovascular issues, arthritis. They may not be motivated. They may not be able to achieve the target, which I said. 5% was achieved in 30%, 10% in 10%. And then there could be an issue of, weight gain. There could be somebody who already have, progressive or advanced disease. So I think I'll not go into the details now because of time, but then all these, problems can be handled by, you can improve the patient's motivation and all by the behavior therapy, multidisciplinary approach. You have now the internet-based approach where people are giving, web-based program, and there are studies available which have been shown to be as good as, physical programs. Even if you have gained weight, your liver fat stays good, your insulin sensitivity stays good. And finally, you can even predict the score by, giving the lifestyle intervention and see if somebody is not responding. Yes, you can go into the pharmacotherapy. And then I think there could be, various extra hepatic benefits of lifestyle interventions, which are absolutely not there, whether these are, the cardiovascular benefits, or this is the same study which looked at the improvement in renal functions with, lifestyle interventions, which will not happen with pharmacotherapy. So this is my summary slide. If we compare the lifestyle interventions alone and the addition of pharmacotherapy, as I said, lifestyle intervention would hit the nail with the major pathogenic mechanism. Whereas pharmacotherapy, you need multiple drugs to act at maybe at metabolic pathways, drugs for inflammation, drugs for, fibrosis. We know there are so many drugs which have failed. Even the combinations have failed, I think. So that's one. Second is we don't have even a single drug which is approved by FDA or EMA, SARO by DCGI, but all drugs are considered as off-label. Societies, yes, some drugs are approved, but again with riders, no drugs for children, no drugs for post-transplant population. Cost, there is no cost involved or minimal for lifestyle intervention, even if you employ the best of, educator or nutritionist. But look at the cost of, the drugs and the clinical trials. Availability could be an issue.
Dr. Ajay, I think I request you to stop
it. Okay, fine. And okay, so I think we'll stop it here. So extra hepatic benefits and all. So the only, I would like to say that those groups who are unfavorable risk factors, not motivated, not responding, I think they can, be considered for, pharmacotherapy. So there could be a select group of people, but in majority of the time, I think the people would respond to lifestyle interventions. So thank you very much, everyone, and I'll stop it here.
Thank you, Dr. Ajay. So now we have the opposite viewpoint and none other than Dr. Abhijit Chaudhary. All of you are familiar with him, and he likes to take the debate to a different level. Go ahead, Dr. Abhijit.
Thank you. Thank you, Dr. Agarwal, and good evening, everybody. So let me start off by telling that I start off with a clear declaration of truce and strip everybody of the pleasure of a bullfight as is expected in a debate. Because as Ajay has rightly pointed out, I think we need to very clearly understand that it's only complementarity of lifestyle intervention and a very clear management plan based on lifestyle intervention as the foundations of therapy in non-alcoholic fatty liver disease and NASH, that we need to consider the entire perspective of NASH therapy, not only today, I think in the years to come also. So let's start with these premises that everybody with NASH NAFLD stands to be a candidate for lifestyle intervention. While he has clearly pointed out that the sustainability and other issues really varies, but everybody is a candidate. I mentioned you cannot have any therapy of NAFLD unless you emphasize on lifestyle intervention. But interestingly, not all persons with NAFLD are going to be candidates for pharmacotherapy. A subset of people are going to be pharmacotherapy based on the current state of knowledge. I'll consider those. But even if they are, again, I emphasize, the lifestyle interventions are going to be key. Pharmacotherapy, as all of us know, is still evolving and emerging, and is a still very hazy area. Although there are many enthusiastic molecules which appear before us only to have a premature demise too fast, but still there are exciting things. Important things will be selection of person, the drugs, and the perspective is going to be the key. But even with the best of the hands, I emphasize again, lifestyle intervention will not lose its relevance. So we all know that the NASH outcomes are pleomorphic, and we need to very clearly understand that NASH is a multi-system disease, and we hepatologists often, including myself, we tend to consider NASH as from our reductionist hepatological perspective. But let me tell you that NASH provides us an internal medicine perspective, and that no other liver disease provides us, and we need to keep that in mind. So when we consider on the left side of the panel that more the fatty liver component people we all know have got cardiovascular outcomes, whereas on the right hand panel that the more fibrotic and the more cirrhotic people are, they have got an outcome which is linked with liver disease. So when we consider NASH therapy, pharmacotherapy, or any variety of therapy, plant therapy, we need to keep in mind that we need to have more of a holistic and composite approach rather than a pure hepatological approach. Otherwise, we are really not going to hit the nail right on the head of it. So we now have got, as I'll discuss subsequently, that we need to consider that why we are, what are the fallacies of treatment that we need to keep in mind? We need to keep that NASH as such is a very varying natural history, and the progression we all know is bidirectional. It's not always progressive, and there are elements in the overall phenotype that can also tell us that some people would progress faster. Overall, 20% progress very fast from F3 to cirrhosis. In fact, Dr. Harrison also pointed this out in less than 2 years' time. This has come out. So we need to figure out who are, in terms of deciding whom to treat, this subset of people who are going to progress to liver-related outcomes, or even all-cause mortality or all-cause outcomes in that, for that matter. And we all know that fibrosis is the strongest determinant, but NASH in terms of inflammation and lobular inflammation and ballooning that we have got is going to be a very interesting intermediate determinant for that. So based on that, our goals of treatment are going to be improvement in the stage of NASH, as we all know, resolution of NASH, these are the ideal goals, reducing the rate of progression, and reducing, we need to keep in mind, long-term liver-related complications, including hepatic decompensation, progression of mild and synthetic dysfunction, but very importantly, no collateral risk of CVD or cancer, or for that matter. We need to keep that in mind also. So this is a large haze of molecules that are visible before us. I don't want to confuse you, because I often get confused, and you need to be, you don't have so many NASHologists right now available right under the sun to understand all these. But to be precise, on the left-hand side, you have got a group of molecules which focus on metabolic factors that contribute to NASH pathogenesis. And you have got several class of molecules for that, which are evolving at many stages of development, some in phase 2, some in phase 3. Interestingly, we know about the acetyl-CoA carboxylase inhibitors, SCD1 inhibitors, of which an interesting molecule in phase 3 is aramcol. I'll soon come to that. But all these metabolic effect molecules are also, at the same time, we have got molecules which target lipotoxicity, some target inflammation, some target fibrosis. As we go downstream, downstream means downstream in the pathogenesis, the battle becomes harder and the endpoints also become tighter. And let me point out that two molecules which we keep on talking, one is obeticholic acid, which is talk of the day in our bedside today, but there are many more FXR agonists of the class, and they have got a pleiotropic mode of action. They are metabolic modifiers. They have got an impact on inflammation and other mechanisms. But interestingly, let me tell you that the molecule that's proud to be an Indian molecule, saroglitazar, that has now interestingly taken a FDA to DCGI path, then a DCGI to FDA path, as I understand, for clearance, is really interesting because it has really shown promise. And there are data that, as Ajay also mentioned, that it's a PPAR combined agonist of alpha and gamma. But there are other PPAR agonists also, which have also got metabolic and other things. And a pan-PPAR agonist, lanifibranor, has really shown promise. But the initial one has really had a sudden demise because it really did not withstand the stress of the trials that one has to go through. But there are other molecules like thyroid hormone receptor beta agonist, resveratrol, and also there are other molecules like inflammation inhibitors, galectin inhibitors, as you go target fibrosis. But some of these, as I put a red star mark like sanicriviroc, selonsertib, simtuzumab, and and elafibranor, all these were very promising till a year back, but have now been shelved and have undergone apoptosis for that matter of molecules. And I'm telling you, many of these molecules will also soon may appear or disappear. But a very interesting set of molecules that are showing significant promise are the GLP-1 agonists, particularly semaglutide and related molecules. Semaglutide, although is subcutaneous administration right now, is a disadvantage, but oral molecules are getting developed. So there are a couple of molecules which are going to be, of promise and of interest, of excitement and vibrance, but it's really a big chart in front of us, and we are yet to be sure how many of them are going to see. As already discussed, resolution of NASH and worsening without worsening of fibrosis, as well as greater than 1-stage reversal of fibrosis have been put, and molecules vary, but none of these exceed more than 30% in the comparative arms. But interestingly, the placebo arms also showed significant response, again telling the bidirectional nature of the natural history of NASH. These are the phase 3 trials that are going on. Regenerate has undergone an interim analysis. It was obituric acid trial. And we all know, we keep on talking for the last 1 year in this country and everywhere in the world with this with the trial and all. I'm not going to detail, but it's still to undergo. It's still to 6 years to accrue and other outcomes subsequently, particularly liver disease related outcome. Mistro and Armour are the two things that are still recruiting. Elafibranor is shelved already, as is ceniculviron. But these are also in phase 3. But the final data, the liver event data may still come. Interestingly, given the fact that single molecules have too often failed to give results, and there are side effect related issues, particularly with obituric acid, significant attempts are on to increase efficacy, increase response rate, maximize response, and also improve tolerability by combining molecules which are overlapping or outlasting or additive. Like, you add in synergy at the same time, or something like Hep C treatment, you initially give 2 molecules together and then you continue with some other molecule. That variety of attempts are on, but that add weight loss, cardiovascular protection, insulin sensitization, lipid protection, apart from the central hepatoprotective and beneficial action that a molecule have to give in terms of to be effective in NASH therapy. We need to keep in mind that cardiovascular disease and other effects are very important in NASH. So I put here several attempts to combine molecules. Some of these are proof of concept. So this is an FXR agonist combined with the ACC inhibitor along with selonsertib, a molecule which has gone to demise. So interestingly, all these attempts are to pull back some of those molecules which we thought are ineffective as a single molecule and put them again into action, combined with something else. Similarly, the basic premises of combination therapy has to be that you need to add 2 molecules with a complementary mode of action and then try to see. But they are still in the early phases of action. Mostly the outcomes are to see whether they benefit in terms of reduction of side effects, but some are also tasting in the context of the basic premises of NASH outcomes and all. I emphasize here that we need to keep in mind that when we treat NAFLD, we treat a complete individual who have got a heightened likelihood of having type 2 diabetes, cardiovascular disease, chronic kidney disease, and all. And each of these add the other together. And we all know that type 2 fibrosis improves possibility of somebody getting NASH fibrosis. And this is a vicious cycle that sets in. So we need to, that's why we have a more of a holistic, collective, convergent, collaborative approach with patient-centric approach, with all these different category of people together, with hepatologists obviously be on the wheel when the person presents to me, but we need to be collaborative rather than being stoic and not to be talkative to other people. And let me tell you that we can have a couple of things in hand to judge if the patient have got type 2 diabetes and inclusivities, and add molecules which are effective for that in collaboration with a cardiologist, or most importantly, an internist and a diabetologist. So we need to do that. So I summarize by telling that therapy of NASH, again, by telling that the lifestyle modification and pharmacotherapy are complementary. And without a lifestyle modification, no pharmacotherapy is going to be successful. Therapy for NASH is moving from behavior to biology. All these, insulin resistance, metabolism, inflammation, fibrosis are promising targets. Many molecules eclipse on transit, many keeps dreams alive. It's very likely that a combination of molecules will be needed. Lifestyle modification would still remain the sheet anchor for therapy. Integration of NAFLD care across disciplines is going to be very important. And I'm really grateful to INASL for this excellent evening that we are having. Again, telling that Roosevelt and Stalin came together to fight a war. They didn't fight, that they had the same white flag and the pigeon in hand. So I extend the same thing to my friend Ajay Duseja this evening. Thank you.
Dr. Agarwal?
Abhijit, you can stop sharing your screen.
Yeah, sure.
Okay. Sorry, I had a problem in switching myself. So both the speakers have, to some extent, come to a middle ground. And I'm sure the audience has some questions. So one of them is, does any of these treatments change the cardiovascular risk when the liver fat is reduced? And that's a question from Dr. Setu Babu. Does anyone of you want to take that?
Yeah, should I take this up?
Sure.
Yeah, none of the molecules as single-handedly, alter any of the cardiovascular outcomes. But GLP-1 agonists have shown some promises based on its early things, given the fact that it also gave you, good results in NASH resolution and fibrosis regression also, and as well as cardiovascular protection in diabetes styles also. So that's some of the projections coming from the.
Thank you. So go ahead, Ajay.
So I think I had shown maybe quickly one meta-analysis by Musso where, out of the various RCTs, at least the 8 RCTs were related to lifestyle interventions. And in addition to improvement in liver histology, they did show improvement in cardiometabolic profile. Your HbA1c, your lipids, your cardiac risk factors, everything improved in that meta-analysis. So I think lifestyle interventions does have, extra hepatic effect rather than the pharmacotherapy. Yeah.
So we've been talking about drugs and we've been talking about lifestyle. How about bariatric surgery? Where do you place that?
So bariatric surgery would be a primary indication for NASH. We understand has still not been recommended in the absence of, one is the RCTs, and second is the kind of morbidity which is associated or mortality associated with bariatric. But yes, if it is otherwise indicated in obese people, say a BMI of more than 40 or BMI more than 35 with comorbidities, the recommendations are that they can be subjected to bariatric therapy, fine enough, and obviously the NASH would improve. So if they have an indication for bariatric surgery, but having said that, if you look at the data on bariatric surgery, for all those patients who require bariatric surgery, less than 1% undergo bariatric surgery. And the reason for that is, again, the preference by the patient, the morbidity, mortality, the cost, the accessibility. I think all those issues involved. So bariatric surgery, less than 1% of the patients would be subjected to bariatric surgery.
So Ajay, why don't you continue? I'll give you another question before I go to Dr. Abhijit. And the question is, basically when we talk about lifestyle changes, we talk about weight reduction, we talk about exercise. How about control of hypertension, control of lipids?
Absolutely. I think if you look at my third slide, when I talked about the kind of lifestyle interventions, the first lifestyle intervention would be to control all the metabolic risk factors. So now whether you're controlling that with lifestyle interventions, your lipids can improve with exercise and with diet, your blood pressure can improve, your diabetes status can improve, or whether you require additional pharmacotherapy, that would be the first thing. So then comes the role of those who are overweight and obese, there comes the role of weight reduction. So I think there's no denying the fact that I think all other risk factors also needs to be controlled well, yes.
So, Abhishek, what is the role of SGL2 pathway that you think will it have a role in the near future?
Yeah. SGL2 inhibitors are also really showing promise, not as single molecule. They are being combined with metabolic modifiers also, and they are in clinical trial. So it's likely that they are going to be useful. But as of now, very initial data exist. They are showing promise. This much can be told.
Let me take this opportunity here to thank both of you. And I don't think we can take more questions. We are already at 8:30. We are far beyond the time. So thank you, both of you. And I hand over back to Dr. Kaushal.
Dr. Kaushal, can we request Dr. Stephen for his comments, if that's allowed?
Yeah, sure. I think we can have a comment from him. Move on to the panel discussion.
Well, this has been an amazing debate. Both presentations were incredible and very insightful. Even somebody that lives in this field, it was great to see the insights from my colleagues in India. So first of all, let me just say, you're both right. Foundationally, we need to have lifestyle modification. And you pointed out the pros of that, as well as the cons of that. The fact that the majority of people, unfortunately, can't lose the weight and maintain the weight loss. And furthermore, what we don't fully understand yet is what the ideal diet is. And we don't know the ideal exercise, the duration of exercise, the intensity of exercise. So, I'm sitting in my clinic yesterday and foundationally speaking this language to my patients. And I'm saying, look, just start doing something, right? Most of these people are couch potatoes and very sedentary. Just start walking the dog, get an excuse to get out. And I use two words, persistent and consistent. Don't do it one day a week and think you're going to make headway, right? The other thing with diet is I tell people there's a difference between a chicken and the pig at breakfast. One is involved and one is committed. You have to be committed, all in. And ideally, cut the carbs, bread, rice, pasta, pizza, tortillas. But interestingly, there's some research recently that I find fascinating, and I want to leave it with the group. And that is, we need to change the ratio of omega-6 to omega-3 acid ratios, because one drives arachidonic acid cascades, which I think is an underappreciated pathogenic mechanism of this disease. Arachidonic acid drives pro-inflammatory mediators that stimulate stellate cells. So eating more omega-3s, reducing our omega-6s, I think will be critical. And then finally, with therapies, we're on the forefront of really rapid advancements. We need the FDA and other regulatory agencies to come alongside us and help us move away from a histopathologic endpoint that's fraught with complications of observer variability, sampling variability, and regression to the mean. However, I want to highlight that there are some very exciting compounds that are modulating not only histopathology, but extrahepatic benefits. And I highlight the FGF21s here, where we're seeing glycemic control, atherogenic lipid reduction, and even to some extent, weight loss. And a more recent molecule, the structurally engineered fatty acids that modulate free fatty acid receptors. You'll begin to hear more and more about that in pathogenesis. These FFARs are really critical to pathogenesis. And these structurally engineered fatty acids can modulate that to a significant degree. And in the interim data we've seen presented by North Sea with icosapentane, we've seen impacts on glycemic control and atherogenic lipids, highly sensitive CRP being reduced by over 50%. So more to come, but I think this is going to be an opportunity down the road to really link pharmacotherapy with lifestyle modification in those people at greatest risk for NASH progression. So thank you for having me on. Again, amazing debate.
Thank you. Thank you.
Thank you, Professor Harrison. So let's move on to the final part of our webinar. Dr. Singh, are you there?
Yeah.
Can you take over from here?
Sure. Good evening to those who have logged in from India, South Asia. Am I audible?
Yes, yes.
And good morning to people from across the Atlantic.
We now have the panel discussion. We have, for which we have all the speakers. And in addition, we have 4 brilliant hepatologists to join the panel. We have Charles Panakal. He's a transplant hepatologist from Aster Medicity, Ernakulam. We have Dr. Abha Nagral, who is a hepatologist and liver transplant physician, working in Apollo and the Sloan hospitals. We have Rachi Maiwal, additional professor at ILBS, New Delhi. I won't say Man Friday, Woman Friday, for all the, the big researcher and the god of hepatology from ILBS. And we have Mithun Sharma, the young gastroenterologist and hepatologist from Asian Institute of Gastroenterology, Hyderabad. So I would like to begin. Has he left? Steve has left, no? Yeah. So to begin with, I would continue the debate a bit forward with Abha. Abha, you must be seeing a lot of NAFLD patients, and many of them must be, before they come to you, they must be seeing a lot of other hepatologists, right? So what's your opinion on lifestyle modification? You think that they receive proper counseling for lifestyle intervention? Because it's often said, lifestyle modification is not feasible in the long run. Okay, people give up, people are not persistent, and that is why we need drugs. Okay. Do you agree with that, or you have, what's your feeling?
Yeah, thanks, Dr. Singh, and thank you, Inasal, for this invitation. We've had a very interesting debate with both the debaters finally agreeing that lifestyle modification is the basis of your basic therapy, following which drugs can be added on. Now, I agree that there are patients who are going from doctors to doctors saying that, I have tried everything, I'm not able to reduce weight and I'm not able to follow the lifestyle. And I think it really needs a physician or a hepatologist, whoever is addressing the patient, to give some more time and counsel the patients well. And towards this, I'll give an example of a bariatric surgeon who came to a hospital to set up a weight loss program. And the first thing he said is that whenever I'm referred a patient for bariatric surgery, I'm not going to be putting this patient up on table the next day. My thing is to first ensure that the patient follows a lifestyle, reduces weight, and is capable of reducing weight. And he set up a team with a dietitian, with a metabolic physician, with a physiotherapist, and very importantly, with a psychologist. Because he said that unless you have a psychologist in your program, it is not going to work, because finally it is your mental makeup which makes you eat or not eat. So I think, just extrapolating that, and it really worked. The weight loss program worked. And one thing which was incorporated in that program was body composition analysis, something which is easy to do, not expensive, much less expensive than a FibroScan. It's a good way to determine the amount of fat, the visceral fat in the body. And it's a good way to motivate a patient who is going through a lifestyle program to tell him that, look, your visceral fat is going down and therefore your risk to develop serious diseases is going down. So I think the amount of time you sit and counsel a patient really makes a difference in them being able to follow a lifestyle. And there, involving the family is important. When you give a diet, the entire family following a diet versus the person isolatedly following a diet. Basic things, slow eating movements are common now and are being popularized. So all these small points need to be emphasized, and a positive reinforcement of somebody who has lost weight by equipment such as the body composition analysis really motivates them further to continue to do that. So I don't agree that it is difficult to follow lifestyle. I think we need to give more time to our patients, give them more positive reinforcements and involve the families, and then give them small tips which we can discuss along the way of how they can, follow diets and how they can follow exercises in their day-to-day routine.
Thank you, Ava. Next, I move to Charles. Charles, we just listened to what Steve had to say on different biomarkers which are being used, and he showed how some combinations can give you results as close as with sensitivity and above 90, right? Do you think those biomarkers, the cutoff levels which are used in literature, which we tend to ape the West, it comes out in the leading journals, Journal of Hepatology and Pathology, and then we start using those cutoffs for our patients. And then, what's your opinion on that? You think we need to have first, before we use them, we need to have our own cutoffs, or do you think that those cutoffs are okay?
Thank you, sir. And the most common biomarkers that we commonly use in our clinic is the NFS score, the FIB4. If the NFS score, a cutoff we use of minus 1.44 to rule out fibrosis, or a cutoff of 0.676 to rule in fibrosis. And FIB4, we use a score of less than 1.3 to rule out fibrosis, and a score of more than 2.67 to rule in fibrosis. But unfortunately, both these scores have been derived in a Western population. And we know that our Indian population as well as Asian population is different. So we need to validate these scores in our population before we can incorporate it into our clinical practice. And we can always combine this scores with the transient elastography. So as already the previous speaker has shown that if we combine a biomarker, transient elastography or MRI, we get a better result. But unfortunately, all these cutoffs has been developed in Western population, and we need to have our Indian standards before we can clinically use it.
Yeah, why I said so, because these have been, the derivation cohorts which have been used in different studies, their BMI and the Indian population we have, the BMI difference is almost 10. It's a huge difference. And that when, put into real, this evaluation gives all wrong results. We published a small study in the JCH that was by Mithali and et al. We found the same NFS and all the things that just didn't work at all. And even I think Samir Shah has shown that, we need to have a different FIB4 levels. So you also feel that we need to, anyone else has to say something on this? What about Rakhi? You think that these cutoffs, please unmute yourself, Rakhi, you are mute.
So I would totally agree with what you've pointed out, and it's a very relevant and valid point that we should not be using the same cutoffs, because we see in Indian patients because of the diabetes, more of central obesity. The phenotype that we see in our country of NASH may be different from the Western cohorts, and therefore it's a need for us to validate and put our own cutoffs in the set of population. That's what I feel.
You just mentioned, Rakhi, that the phenotype of NAFLD we see a different from the phenotype which is seen in the West.
Yes, sir.
Right?
Yes, sir. We see more of central adiposity, and this is more common in our population because of the diabetes. Insulin resistance I feel it's more marked as compared to the Western. So we have more lean population of all those. Also, these studies in India have suggested the proportion of patients with lean NAFLD are also higher in our country. So
since it is different, we have now a proposal. Basically, it all started in the in the West that NAFLD should be renamed MAFLD, right? And even in the Southeast Asia, there have been people who believe in this. You think that by changing NAFLD to MAFLD, we are going to benefit in any way, vis-a-vis treatment, vis-a-vis I mean, research or whatever?
Nomenclature only becomes a... So nomenclature wise, I think so. Only problem comes while we are having non-alcoholic with alcohol-related liver disease. There only you are having a challenge to put non-alcoholic. Otherwise, I don't feel nomenclature is will make any difference in the overall. That's my understanding of the.
Okay, thank you. Yeah, we agree on this. Don't worry. I also.
Dr. Singh, can I add to this?
Sure.
This NAFLD, the pediatric hepatologists don't agree with it at all, because they say when you say metabolic associated or whatever, then you're talking of metabolic diseases in children, and it's a great confusion. So they don't agree on this NAFLD at all. If you look at the pediatric hepatologists, in fact, they said it should be just called fatty liver disease in children or stick to NAFLD.
Good. I have another reason, another thing in my armamentarium to fight NAFLD. Okay. Next, we move on to Mithun. Yeah. Mithun, you seem to be fond of lean NAFLD, right? You think lean NAFLD is a different entity, completely different from normal NAFLD? And next question is, there is part one of my question to you. And the next thing is, what would you say, drugs or lifestyle for lean NAFLD?
Right. So as Professor Duseja rightly showed in his initial slides, that 10% of our population are possibly lean, or what I can call them as non-overweight or normal BMI fatty liver. In our study, which we recently published, there also we found it to be around 6.6% of around 150 patients. Now, the question here is whether the metabolic things in lean NAFLD, whether they are different from that of an obese NAFLD, whether the genetic factors play a more role in a lean NAFLD than in an obese NAFLD. So what we found out was that the insulin resistance was significantly lower. I understand this varies from data from ILBS, where it was found to be similar, but this lipidemia was also found to be slightly lower and statistically lower in patients with lean NAFLD. So insulin resistance, we found it only around 12 to 15% of patients, but this lipidemia was there in around 30% of those lean patients. These are pure lean patients. We have done a genetic analysis for PNPLA3 and TM6SF4, and we found that these were there in almost 80% of the patients with lean NAFLD and around 60% with the obese NAFLD also. So that was not a very significant parameter. We also compared their diet pattern, their exercise pattern by taking a recall history. There was no difference actually, but although there was some amount of higher aerated drinks intake in the obese group. So when it comes to the treatment part, I have a 45 kilo person sitting in front of me, and I tell him that the only treatment of NAFLD is diet, exercise, and 10% weight loss. He gives a big stare at me because he says, "Me, you are talking about weight loss?" But then I try to counsel him that even if you lose 2-3 kilos, which may be as low as 5%, because studies have shown that if they can lose even 5% of weight, they still benefit, because many of these lean NAFLD still have visceral obesity. So that they still benefit from this. Coming to drugs, definitely the indications of drugs in lean and obese NAFLD, the trials which have happened did not take BMI as a criteria for inclusion into the trials. So the trials with the drugs included patients with normal BMI as well as obese patients. So the drugs should not be different when and as it is indicated.
Anyone else has to comment on lean NAFLD?
Dr. Mithun, would you like to comment also on the histology?
Yeah, we have the histology. So there have been data where it is shown that they have possibly a more aggressive course and more amount of inflammation in lean NAFLD. So we are doing a study where we are doing a paired biopsy study on a very few number of patients, though it's around 25 patients, where we see the histology pre and post exercise. But definitely when we compared the biopsies of lean and overweight NAFLD, what we found out was that there was some amount of inflammation which was not statistically different from obese, but definitely the NASH scores were significantly higher in these patients with lean fatty liver.
Thank you, Mithun. Kaushal? Kaushal, can we go on for some time, or?
So if you have any, if you have pressing issues, or the panelists have any pressing issues to discuss, I think we can go on for next 5 minutes, and then I think we'll close.
Can I make a comment on in terms of management of lifestyle between lean and non-lean obese NAFLD? I think in lean NAFLD, since weight reduction probably is not the primary goal, you would, in terms of exercise, focus more on resistance exercises to build up muscle mass rather than exercises like cardio, which will increase the target heart rate and reduce calories and reduce the weight. So I would say that may be one difference in terms of exercise.
And if you take that history, most of these patients have a sedentary lifestyle and poor eating habits. So that usually, whether they lose weight or not, whether they go on to changing their lifestyle itself helps.
Ajay wanted to speak something.
Yeah, I just thought, let me add my thoughts on this. So the regarding, the cutoffs which you were discussing, I think I absolutely agree that the cutoffs have to be, population specific. And we have a paper now accepted in JCH for the FAST score for Indian population. So we have, come up that the FAST score is very good for predicting NASH, but then it also depends on the prevalence of NASH in your population. So your cutoffs would be different, and we have come out with different cutoffs. I think that should be in print very soon. The second thing is about the lean and the lifestyle interventions. I could come across one study from Bangladesh from the South Alam's group. Very small number of patients, but I would say they have actually given up this concept that even within the lean, normal BMI, if they are able to lose some weight, I think that really leads on to histological improvement. And that, I think the point which Dr. Mithun was making, I think I absolutely agree that even if you have normal BMI, don't ask them to lose, 10%. So even 3 to 5% would be good enough for them, and exercise alone may be good enough for them. And I think it does help. Yeah.
Ajay, I have a unique mantra for your patients. What we saw when we were analyzing our data, we talk of, it is the BMI of 23, 25, this is what most of your patients won't be having less than that, right? And your target must be, you must be happy with even 24 BMI or 23 BMI. When we looked at the patients and saw at what cutoff BMI the prevalence of fatty liver shoots up, it is not 23, it is not 25, it is 22. 22, below 22, fatty liver prevalence is around, 10% or 11%, right? Once the BMI goes above 20, even between 22 and 23, it is much higher, double than that of below 22. So people often say BMI is nothing, don't bother about BMI, we have base and the other thing. But very simple, BMI is, I have still not abandoned BMI, and my target for my patients is a BMI of 22, right? And what I tell them is, you multiply by height, you get the square of your height in meters and multiply that by 22. And I give them in writing. Now you exercise, you eat whatever you want to eat, you do exercise, you can eat rasgullas or you can eat whatever chapati. But within a reasonable time, you get your weight down, and next time when I see you, you must lose 2 to 3 kgs weight when you come to me later, say after a couple of months or so. If you don't come to me. It is very easy. And that works.
And I think the other point I thought, which I couldn't really elaborate in my presentation, was, the kind of multidisciplinary approach which is required in these patients. Our Indian OPDs are so busy especially the, the public sector hospitals, you don't have time for your patients. Ideally, they need a psychological counseling. They need a dietitian support. They need a physical trainer. They need not only a hepatologist or a physician, maybe a diabetologist, maybe an obesity specialist, that kind of multidisciplinary, which is lacking at least in us. And I think if you have those kind of this thing, I'm pretty sure, I think the number of people who can achieve 5% to 10% weight reduction would probably go up. This is my thinking. Whether it's practically possible or not, I think that's a big question here.
I think, Ajay, this can happen in a setting where you have in the corporate hospitals where the patients from the upper strata come. Okay, they come for a consultation. They can have 10 consultations, and they go back. They can come again and again.
Yeah.
But for most of the country, or that is Bharat, that is India versus Bharat. For most of our country, the patients come from a background. It's very difficult for them to come a second time. Absolutely. They want to return to the village as early as possible.
So that's what I'm saying. You must have in the clinic, in-house, all 4 or 5 integrated people, that kind of fatty liver clinic going on, where have, those 5 consultants or, 5 specialists sitting and kind of advising. I think that's, I know it's not practical. Yeah.
It's not practical in most of the setups, right? So I think we had a wonderful panel discussion. And with this, I thank all the panelists. And now hand over the stage to Kaushal for taking the meeting forward. Kaushal and...
I think cannot take it forward now. It has to close. But before I close, I must say that a lot of meetings had been going on for NAFLD. I think every 2 to 3 months, there have been webinars on NAFLD. And every time I think that, oh my God, what more I can learn. But thanks to the speakers and the panelists and the chairperson, who every time bring about so much things new to learn in NAFLD. Thanks to all the speakers and the panelists and the chairperson, done a wonderful job here. Thank you so much. I think all of us, including the audience, learned. I've been told that there was more than 800 people at peak time when who had joined and possibly gained from this meeting. And in the end, I must also thank our educational partner Zydus for making this possible. And I know they have been after us to host this particular program for last couple of years, but this time they did it. Thank you so much, Zydus. And thanks once again to all the faculty. Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.